I think, so can I ask you, I know it's been a long session, but we need to get starting, please. Carlo is not helping with that either. We want your input on that session, so don't leave. Okay. So this is an industry session. It's a Boston Scientific session. And you can grab your coffee, walk in right back. This is meant to be an interactive session. And over the past couple of days, we've seen excellent live cases where there was heavy emphasis on the use of intravascular imaging, adjunctive tools, either for MCS or for calcific modification. But we've seen how the essence or how critical this is to ensuring both short and long-term outcomes. Now, it is meant to be an interactive session, so we will be pausing and hopefully getting some input from the audience. And the audience are not around, but it gives me great pleasure to start with Dr. Abdulaziz Al-Gethami from the National Guard Hospital in Saudi Arabia, and we'll get started with the first case. Dr. Abdulaziz.
Thank you very much. It's a pleasure here to see all the program also supported by Boston Scientific to invite me and confirm the cases that it has been actually will be shown to confirm what has been done in the past. So instead of going over details and kind of what other colleagues did, which they did a great job in reviewing all the evidence, I will just show some of the cases that we did, and we'll go over some of the discussion about it. So I'll speak briefly about calcium burden and therapy, and then we will see a case presentation. We'll go over the challenges and what are the tools that we actually used. And then we will see another challenging cases, but we will not go over more details. It's just to show up how much calcium impacting us. So that had been shown previously. We did actually have many evidence that's been raised in the previous years. We did show that the stent expansion goes with higher arc of calcium, as well as the need of retabulator or the use of retabulator. It's been increasing with increasing the arc of the calcium. And the impact has been actually seen in also the outcome of the patient. The more calcium you do see, the more kind of complication, target vessel revascularization, MACE, as well as MI, with more calcium you do see. The evidence also grows because we have more kind of studies that have been going on over the past few years. I will not go over details. There is many other colleagues that did presented these data. I just want to go straight to the case. So this is a 77 years old, body mass index 33, limited mobility, angina class 3, past medical history, diabetes and insulin, hypertension, EGFR of 19 with creatinine of 230 because she is a small lady. She'd been admitted previously with non-STEMI and decided for medical therapy because of risk of CIN and dialysis, as well as to give her a try of medical therapy due to the extensive of the disease. Her current actually presentation is another ACS. The echocardiogram showing ejection fraction of about 50%. The distal anterior wall and apex, there is some regional wall abnormality. So this is her angiogram. As you can see, there is a calcium long lesion in the LAD. It's involved also the diagonal medium small size. The circuit seems to be fine in this view. We'll see a different view for that, but it does supply the RCA, which is appeared to be a CTO likely. We did not do so many views because, as you know, the EGFR is about 19 only. So we did the cranial and caudal. You have a lesion also in the circ, which is about 80%. The RCA is CTO with some antegrade and retrograde filling. So decision pathway in the heart team, the discussion combined meeting, this is a 3 fissile, diabetic, the patient wishes taken in consideration. There is a risk of CIN as well as a risk of dialysis in either ways. Of course, with somebody going with EGFR under cabbage, probably he will go to dialysis. What are the revascularization options that are available for her? What other patient comorbidities given her limited mobility and small in size? So probably all agree that this is possibly the best approach is to go for BCI. Does anybody disagree with that?
I think, Abdulaziz, if you don't mind, we can pause at this stage, and I'm seeing a few good faces. Gabriele. So, elderly lady, a complex clinical scenario in terms of CKD, a bit of obesity, very limited mobility, and RCA-CTO and a long calcified lesion in the LAD. What would be your strategy?
Okay, so my strategy would be an ultra-low contrast PCI of the LAD using imaging to guide right strategy and also to reduce the amount of contrast. In this case, I think that there is no need for any ventricular assisted device because of good ejection fraction.
Very good. Carlo, single procedure, stage procedure, how would you handle that?
Well, first of all, I think it's always a mistake not to do a coronary angiogram when you have a non-STEMI. You have to under creatinine, you have to reduce the amount of contrast, but doing the diagnostic angiogram, 2 views of the left, 1 view of the right, 15 ml of contrast will not send the patient to dialysis anyway. And then you can do the procedure, as Gabriele said, basically without contrast. Our colleagues in New York made their name, Ziad and colleagues, using zero contrast. They even do it with OCT, injecting saline instead of contrast, but I normally do with intravascular ultrasound. I put the old image on the screen. I don't inject before the procedure. I just put my wires based on the old images. Then I check with the imaging that I'm in the right vessel and size of the vessel. I see the result with that. You may need a puff of contrast at the end to check flow. That's it. I will personally stay just for the LAD. In this case, you can do a almost contrast free procedure also for the occlusion if you go retrograde. In this case, I will go retrograde mainly for this reason, not for because it's impossible anterograde. Of course, you need at that point viability to be confirmed, however.
Excellent points. We've seen so many patients be left behind and denied revascularization because of the risk of CIN. But if you end up with ischemic cardiomyopathy, this is arguably the worst thing that can happen to the kidney, not to mention jeopardizing the patient's life. Whereas I have to ask you one question, and just to get you off the phone. Now, can you afford doing this case without intravascular imaging? Would this be good practice, or is it at all affordable?
I think if you're in the lab that you're planning to do a complex lesion like this calcification, I think we cannot do it without imaging. And I think we're going to beat the surgeon with our multifissile BCI by doing it appropriately. And you cannot do it appropriately without imaging. You need to size your fissile, you need to see your stent after. Regardless the imaging you're going to select, either go OCT or IVOS, but if you want to be a multifissile BCI operator, and if you want to be a complex BCI operator, you have to have an imaging in your system.
So I guess Carlo also raised, yeah.
One good approach to save contrast and still be able to image with contrast is to use from the very beginning a selective guide liner. So you don't inject into the corner, you inject directly into the vessel you want to treat, and everything becomes much better, you see better. You use only 2 or 3 cc of contrast each time and you see much better, and you don't waste the contrast in the coronary sinus or in the circumflex if you're treating the LAD.
Excellent point, Dr. Kram. Absolutely excellent point. And I love what Carlo also said about if you go retrograde from the outset, this becomes essentially, once you cross that septal perforator, then there is zero contrast from there on. So Abdulaziz, we're all eager to see how you managed to help this lady.
Okay, so definitely patient, decision was to go for BCI due to all these discussion that we did had. Our plan initially to go for the CERC and the LAD, and later on, if the patient is still symptomatic, we will go for the RCA. What are the challenges that we're facing? There is actually a long lesion in the LAD. Definitely, it's a diffuse small vessel disease. There is moderate to severe calcification. The diagonal is a medium size. When we're dealing with these lesions, we have to consider that it's sublined also the RCA, which is almost CTO. And the creatinine is actually high. So given all this, we proceeded with planning. So we need to plan the case. Imaging, as you mentioned, all that it should be considered. And because of the CKD, definitely we'll look for an IFAS. The bifurcation with the diagonal, we have to think about. We don't want to lose it if that's possible. Calcium modification strategy, which because of that long lesion, probably we're looking for kinds of rota or kind of orbital atherectomy. And we want to confirm that we use a low contrast used. If it's a single stent, it's possible because it's a long lesion. If it's not, we have to go for a 2 stent. So these calcified lesions have all the kind of publication going on. I think I go with that kind of agree that when you do have severe calcification, it's like a road trip. Probably extra kind of imaging, it might help to deviate our decision regarding deep calcification, but most of the times, this deep calcification is not well studied compared to the superficial calcification. So the superficial calcification is where the money is, where is the thickness, where is the things, where is the arc. So if you do see all these superficial calcification and you see it before and severe calcified artery before angiogram, probably you will make the decision for going for either rotablation or other modality depending on the length of the lesion. So in that case, probably you don't need to image, but you need to image it for a different reason, which is you need the sizing of the vessel. You need to know how long or how big is the stent. But if it is actually severely calcified, probably from the beginning you will decide this is going to be a calcium modification therapy. Either the way, without further ado, so these are the tools that we do have. I mean, definitely there is a specific use for one and one over the other.
We were eager to see what you actually did because
yes,
we're running short
go
of time.
for that.
Yeah.
So I did go for the CERC quickly because I don't think it's calcified that much, and I thought with 2cc will definitely reach to a good expansion. As you can see, it's pretty good expanded. It's oversized stent. Then we did go for the OCT, or for the LAD, we did actually dilated. We put the IVUS. This is the imaging before actually we stent. So distal vessel is around 2, proximal is around 3.0 or 3.5. So if you run the images itself on the OCT, on the IVUS, you will see actually the calcium arc in the middle. And also, after the lesion, you can see the opening of the diagonal in a good size, where it is actually coming in, which is a little bit reassuring. There is not a lot of publication going about that, but maybe in the future we can actually get used to it more, and we can see that the patient actually might have more kind of reassurance about what they are going to do. So these are the calcium, and the diagonal actually now coming in, which is a good vessel size. I mean, from perspective of the ostium coming, taking over. So this is a calcified lesion. It's more than 200 or at least 230 calcified. We decided to go for a rota.
For you.
1 minute, we'll go quickly.
Yes, please.
So because of the lesion, we decided we needed a long lesion that can be expanded proximally based on the stent. We did rotablate. We did put the stent. Then we did an IFUS. The IFUS shows distal vessels about 2.0. We optimized more, and proximally is 4, but it is diffuse leaf vessel disease. We optimized more with having 3.0 proximally to 5 distally. This is the final result. Then we are looking for acute gain versus further optimization. We did had a low contrast. Do we need to optimize more? This is small vessel disease. Do we stop? We decided to stop. We're happy with the result. Then we looked at our contrast. It was about 25 cc. The troponin next day is 58. 12 minutes follow-up is the patient is actually doing very well.
Very good, without revascularizing the RC. She's
We didn't
asymptomatic.
actually. She's limited mobility and she doesn't have much of symptoms. We didn't jump unless the patient have symptoms on it.
Very good, very good. Thank you very much, Dr. Abdulaziz. Thank you. 25 cc's of contrast, I think that's good.